Welcome to The Explainer. I am super excited to have you here today because we're kicking off an absolute game changer of a 10-part masterclass titled Decode Healthcare with Harshal. In this first part, we're going to zero in strictly on the clinical foundations of wound care and, more importantly, the monumental coding paradigm shift that's heading our way in 2026.
Okay, let's dive right into this. I want to ask you a question. Is correct CPT code selection enough to prevent wound care denials in 2026? I need to be completely blunt with you here. If your answer is yes, you are walking your practice straight into a massive audit trap. Historically, sure, if you got that 5-digit code right, you got paid. But in 2026, choosing the correct code is literally just step one.
Here's the harsh reality for 2026 that we all have to face. Your new baseline formula for reimbursement is the procedure plus the proof of medical necessity. If you don't want to lose hard-earned revenue or, even worse, face steep clawbacks from payers, you've got to fundamentally shift your mindset. Documenting clinical improvement now carries the exact same weight as picking the right CPT code, period. This new formula is your absolute baseline for avoiding claim denials from here on out.
To make sure you're fully protected, here is our roadmap for today. First, the 2026 paradigm shift. Second, foundations and wound types. Third, the 5 types of debridement. Fourth, a quick interactive knowledge check. Fifth, the medical necessity baseline. And finally, summary and next steps.
Let's move right into Section 1, the 2026 paradigm shift, code versus necessity.
Historically, we focus so heavily on our technical CPT codes, your 11042s through 11047s, and 97597 through 97598. And from a strictly technical standpoint, those code sets haven't changed at all. But under this new payer scrutiny, you can code a claim flawlessly, absolutely perfectly, and it will still be denied if your documentation lacks proof of clinical improvement. What does this mean? It means coding teams aren't just doing data entry anymore. You are now the compliance gatekeepers for your entire facility.
Section 2. Foundations and wound types. Visual classification.
Let's move from abstract coding rules to the concrete reality of clinical practice. To document effectively, you have to know exactly what you're dealing with. You're going to encounter a really vast spectrum of wounds out there. We have abrasions, which are essentially scraped or grazed skin, lacerations representing torn cuts, punctures, which are deep, small holes. We also have clean surgical incisions. Then we see avulsions where tissue is actually tearing away. Moving into chronic territory, we find pressure ulcers or bed sores, diabetic ulcers, which notoriously stall in healing, and burns caused by heat or chemical injuries. Recognizing and explicitly documenting these exact differences is the absolute foundation of medical necessity.
But before we can actually code for treating these wounds, we have to precisely define our primary intervention. Wound debridement is the process of removing dead, necrotic, or infected skin tissue to help a wound heal. It clears out the unhealthy tissue so the healthy tissue actually has the physical space and the right environment to grow. Now, it's absolutely vital to remember that debridement is not required for all wounds. It's typically reserved for wounds that are infected, chronically failing to heal, or actively getting worse.
Which brings us to Section 3, 5 types of debridement, clinical modalities.
Now, what's really interesting about this is, if debridement is actually required, how do clinicians go about removing that devitalized tissue? Well, there are 5 distinct methods used in clinical practice. They range from sharp metal instruments, to specialized dressings, to chemical ointments, and even natural biological helpers. Let's break each of these down so you truly understand the clinical actions going on behind the codes.
So here are your 5 core modalities. First up is surgical or sharp debridement, where a doctor actively uses a scalpel, scissors, or a curette to physically cut away the dead tissue. Second, we have mechanical debridement. This utilizes things like wet-to-dry dressings or wound irrigation to physically pull or wash away debris. Third is enzymatic, which involves applying topical chemical enzyme ointments to slowly dissolve the dead tissue. Fourth is autolytic, using moisture-retentive dressings like hydrogels that actually harness the body's own natural enzymes to clean the wound. And fifth, biological, where sterile medical maggots are applied directly to the wound to selectively devour dead tissue while leaving the healthy tissue completely intact.
Let's shift to Section 4, Interactive Knowledge Check, Scenario Benchmark.
Okay, I want you to lean in for a second because it's time to put this clinical knowledge to the test and see if you can think like an auditor. Here's a quick scenario. If a provider performs a simple wet-to-dry dressing change and irrigates the wound, is that considered true selective debridement for coding purposes? Think about it for a second.
So the crucial point here is absolutely not. No way. Simple dressing changes, even when you include irrigation, do not qualify if you aren't actually removing devitalized tissue. CMS guidelines are super specific here. Wound dressing changes alone are not reported as debridement. The golden rule is incredibly simple. No dead tissue removed equals no debridement CPT code billed. Honestly, this is one of the most common real-world coding missteps out there.
Let's jump into Section 5, the medical necessity baseline, documenting the why.
So we know what debridement is, but how do we prove we actually needed to do it? Here is your ultimate necessity checklist to bulletproof your claims. Your documentation must clearly establish 4 key things. 1. The clinical reason for treatment today. Why wasn't standard conservative care enough? 2. The explicitly documented presence of devitalized tissue. 3. Exact wound measurements, particularly the depth, because coding follows the deepest tissue removed. And 4. Measurable evidence of the healing process. I really want to stress this. Repeat debridement procedures without documented, measurable healing progress are a massive audit trigger right now.
And here's a huge pro tip to protect your practice. You have got to avoid vague, subjective terms like improving, looks better, or healing well. Auditors and payers absolutely despise those words because, frankly, they don't mean anything clinically. You must use measurable changes. We're talking exact surface area reductions in centimeters, specific changes in the color of the wound bed, or exact reductions in necrosis. Data is your defense.
Finally, Section 6, summary and next steps. Wrap up.
Okay, if you retain absolutely nothing else from today's explainer, please lock in these 3 key takeaways. Number 1, the 2026 rule demands the procedure plus the proof of medical necessity. Number 2, always base your CPT codes on the deepest level of tissue safely removed by the provider. And number 3, you must document exact, measurable healing progress if you want to avoid those devastating routine care audit traps.
Now, before we wrap up, I want to leave you with a bit of a provocative thought. Imagine you have 2 separate wounds on a patient. One is 10 square centimeters and the other is 15 square centimeters. How do you aggregate that surface area math to bill correctly without triggering an instant denial? Well, we are going to answer that exact puzzle in Part 2, where we take a deep dive into selective debridement codes 97597 and 97598 and master those surface area calculation rules. Thank you so much for joining me. Keep your clinical documentation crystal clear and continue to decode healthcare with Harshal.